Rounds. I'm Dr. Mike Dewberry, Medical Director here at the IOL, and it's my pleasure to be able to introduce Dr. David Pepper, who will be giving today's grand rounds. And he really probably doesn't need an introduction for most of you since he's well known to all of us. But for those who don't know, Dr. Pepper's been with us for 18 years. He's the director of the Emergency Psychiatric Services here. He trained at the University of Connecticut and IOL combined residency program, and then did a psychosomatic medicine fellowship here at Hartford Hospital after that. His areas of specialty are palliative medicine and psycho-oncology and emergency psychiatry. And he's been very active in teaching. He's been recognized in having won the IOL's residency teaching award, and also the University of Connecticut's Emergency Medicine Residency Friend of Emergency Medicine Award. And his current clinical duties include emergency psychiatry, consult liaison psychiatry, and HIV psychiatry. In 2015, he was appointed as the chairman for the membership committee for the for the American Association of Emergency Psychiatry. And he's been quite active on that level, really advocating for national standards and to enhance the care in the emergency psychiatry area. So I'll turn it over to Dr. Pepper.
All right, thank you, Mike. Hopefully everybody can hear me and see me okay. When I agreed to do this grand rounds, I was really hoping I'd be doing it in person and being able to see a crowd of people and get some real-time feedback from people, but we are where we are, and we'll move forward from here. So as Mike mentioned, my early training in palliative medicine, psycho-oncology, and end-of-life care, can seem like a bit of an odd shift to get to emergency psychiatry, but I actually think it's pretty complementary that, we both fields work with really sick people trying to provide acute symptom relief. And communication is really key for both fields. And I really feel that early training really helped me become a better emergency psychiatrist. All right, so the financial disclosures, I have no financial disclosures to make. The one potential conflict I have is a non-financially endorsed position with the American Association for Emergency Psychiatry as their membership chair and as their assembly representative. Here is the CME code for all of those that you who need CMEs from the talk today. Hopefully somebody will put it in the chat so other people can get it later. All right, so since
Dr. Pepper, your slides seem to be stuck and not in slideshow mode.
Oh. They are advancing on my screen. So what are you seeing?
We see the whole layout of Microsoft PowerPoint, like when you're creating the PowerPoint deck.
Yeah, it's not advancing, it's just sticking on the title slide.
I will start again. How was that? Did that work? Can you now see the CME disclosures?
We see your screen.
It's still just the title slide.
Do you have one screen or two?
Two.
That's probably why.
So maybe come out of slide presenter view and just the layout that Sarah mentioned, stay in that view and click along the side to advance.
All right. So now, do you see it advance? Okay. We'll make it work. All right. So as I said, no financial disclosures, and here is the code to get CME credits. All right, and here are my learning objectives. So since the designation of areas in general medical hospitals to care for the acutely ill, so basically when patients needed acute treatment and they couldn't go to see their doctor, those institutions have struggled with how to handle behavioral health emergencies, how to handle patients with psychiatric and substance illnesses. I'm going to review the history of that, what some of the current practices are, and then some of the future directions where I see this field going. So I'd be remiss if I didn't start with emergency medicine and their history, since they're so tightly entwined. Internationally, emergency medicine started probably around the 1700s during the French Revolution. In particular, there was a medical officer who designated carriages to carry wounded troops back to a centralized location to receive medical care versus seeing them in the field. I actually only recently learned that it was also the fact that the French government shut down hospitals at the time, that they needed to provide all of this care on the field because there weren't places to take people. But either way, you can see the true benefit of a seriously wounded soldier getting immediate treatment, and even the moderately wounded soldier not getting treatment on the battlefield, but actually going in front of a real physician, getting treated, and then being able to return to the field. In the US, emergency departments as we know them really started taking shape in the 1960s. Before that, emergency departments were staffed by interns, residents, surgeons, family medicine doctors, and rotating specialists. And it wasn't until the 1960s where a group of staff members decided to dedicate their field of interest to taking care of the patients in the emergency department. So not focused on organ disease or a particular organ of the body or a disease process like most other medical specialties. They focused their care on the acutely ill or injured, no matter what the cause was. So these departments started a national movement in the 1960s and really led to the formation of several different emergency medicine societies. And over the next decade, they expanded their body of evidence and really showed their worth in providing care to patients, to improving flow in the hospital, and allowing those specialist physicians to really practice their specialty more efficiently. It wasn't until the 1970s, though, that the American Medical Association finally recognized emergency medicine. And then a little later, there was the first emergency medicine residency program. And it wasn't until 1979 that the American Board for Medical Specialties actually recognized emergency medicine as a board eligible specialty. So quite a long journey to get recognition. It always surprises me that it took so long for a field that I feel is so specialized right now, is so different than every other field, that it's really hard to believe that it took them so long to get recognized. Now, psychiatric patients that presented to emergency departments in the 1960s were faced with a much different view than they are today. So most of the time they were evaluated by the emergency medicine provider. They could ask for a consultation from a psychiatrist, which would be a psychiatrist coming from another system or another practice to come to the emergency department to help determine the right treatment for the patient. But there really wasn't a lot of sophistication in the disposition, in the discharge planning from the emergency department, what could happen from the emergency department. It was really, do they need to be admitted, or are they safe to be discharged? And in talking to one psychiatrist who worked in New York City in the 1950s and 60s, really described it as he could discharge people to a local psychiatrist that he knew they could follow up with. He could have them wait in the emergency department for a state bed, or if they had resources and money, he would give them the address of a private psychiatric hospital where they would go and present themselves to be admitted. So a very different system of care, very different processes for admission than we have nowadays. But you can really see where there was tremendous need for growth. The origins of emergency psychiatry are actually tied to one of the most pivotal legislations concerning mental health in the 1900s. So the Community Mental Health Centers of 1960, Community Mental Health Centers Act of 1963. It's been known as a few different things. It's had a few different name changes over the years, but it's had a pretty profound effect on the way that mental health care is provided. Some negative, some positive, but definitely a profound effect. So for those of you that are not aware of this bill, it was an attempt by the US Congress and President Kennedy to overhaul the mental health system by improving the entire system of mental health, by changing the focus from inpatient treatment to community-based treatment. The vision was to fund the opening of community-based treatment centers that would change the way we approach people with mental illness, to focus on early community-based treatment instead of long-term inpatient treatment. And I'll read the quote. It may be hard for you to see. This was during President Kennedy's presentation to Congress. He said, "I'm proposing a new approach to mental health, mental illness, and mental retardation. This approach is designed in large measure to use federal resources to stimulate state, local, and private action. When carried out, reliance on the cold mercy of custodial isolation will be supplanted by the open warmth of community concern and capability. Emphasis on prevention, treatment, and rehabilitation will be substituted for a desultory interest in confining patients in an institution to wither away." So it's a pretty damning statement on inpatient psychiatric treatment at the time, which I think was a dramatic approach to get a response. Certainly wasn't the state of all inpatient psychiatric treatment at the time, but like here at the Institute of Living, we've been doing treatment for 200 years, but there certainly were places where it was more custodial care and more about confinement than it was treatment. I do think his proposition for alternative treatments was correct, that there needed to be this bigger push. And I wish 60 years later that we had achieved all of the things that he had spoke about and really designed to come out of this legislation. He asked for enhancing current inpatient treatments, enhancing training of psychiatrists, psychologists, social workers, and psychiatric nurses, additional research in mental health, and then establishing community mental health centers that would provide, as he described, diagnostic and evaluation services, emergency psychiatric services, outpatient services, inpatient day and night care, foster care, and even rehabilitation. So the CMHA funded 3 years of federal grants totaling $150 million, and the design was to set up 1,500 community mental health centers. Unfortunately, only about half of those mental health centers were ever built. Most were funded for that period of time, but not sustained over time. The states used the money in different ways. They each designed their mental health centers in their own way. There wasn't a nationalized approach to it. So at the time the act was passed, there were about 800,000 patients in psychiatric hospitals, and the average daily expenditure was about $4 a day. And the average length of stay was judged in years and months, not in the days that we think about today. So what did it change? What change did the CMHA cause? Well, it did cause a dramatic decrease in inpatient psychiatric beds. So if you look at the episodes of care, we went from 1955 having 1.7 million episodes of psychiatric treatment, where 3/4 of those, 77%, were all inpatient. You flip that to 1994, were 10 million episodes of care. So we had a dramatic increase in access to psychiatric treatment, but only 26% of those were on inpatient. So a much larger focus on outpatient treatment. And we did have a dramatic decrease in the number of hospital beds available. The result was also a dramatic increase in emergency room presentation for patients with psychiatric illness. New York City has some of the best data around this time. They saw a 16-fold increase in emergency psychiatric visits and a dramatic increase and shift towards involuntary hospitalization versus voluntary hospitalization. The emergency psychiatric services at the time were described as chaotic, disjointed services, and they would vary from hour to hour, whether emergency departments were covered by psychiatrists or not, whether they had people in the emergency department to evaluate people with behavioral health disturbances, vary tremendously. So what was the response to this? I think I skipped a slide. In the 1970s, you had psychiatrists from around the country who are dealing with these patients now, suddenly inundated with thousands of patients presenting to their emergency department with acute psychiatric illness. And they were looking for help. So they approached the American Psychiatric Association, who formed a task force on emergency psychiatric care. This was headed by Gail Barton at the time. And she really did a tremendous job of putting together a group of people from around the country that were doing the same work, doing it successfully in their region, trying to figure out what worked, what didn't work, and trying to share their experiences nationally. So they created their own definition of what an emergency psychiatric disturbance is. They set standards for emergency psychiatric care. One of the big things they actually did also was provide education to psychiatrists. They went on the road, they gave talks at national conferences on emergency psychiatry. They set up educational models, particularly around disposition, around how do you choose the right level of care for a patient. They even got into the optimal staffing for emergency departments and even the architectural design of emergency departments, what they should look like. Unfortunately, most of the standards weren't publicized. So the APA chose not to publish their standards. Therefore, they weren't recognized. They weren't seen nationally and implemented nationally. One of the big long-lasting effects was the formation of the American Association for Emergency Psychiatry. And as Dr. Dewberry mentioned, I'm a proud member of the board. And it was formed by people from this committee, as a result of this committee, as a result of these patients presenting to the emergency departments and overwhelming services. And it really gave psychiatrists a place to go for education and camaraderie around treatment of emergency psychiatric patients. The American AAP is a American Psychiatric Association affiliate, but it really promotes the advancement of evidence-based and compassionate care for behavioral health emergencies through research, education, and interdisciplinary collaboration. So it's one thing that the organization is very proud of, is the fact that we do, it's not for psychiatrists only, it's not a physician only organization. We are multidisciplinary because we know this care needs that, requires that, and that's the way we provide the best treatment. So the organization still is in effect today and growing. We now have more affiliations with the American College of Emergency Physicians, the National Association for Mental Health, and several other national organizations to continue to promote emergency psychiatry. So over the next 15 years, unfortunately, there wasn't this national standard. We didn't come up with a way for people to integrate their services. So each system was kind of on their own, trying to adapt their own emergency department, their own emergency psychiatric services to fit their need. And again, there was a kind of uproar around the lack of standard of care for these patients. So the American Psychiatric Association again formed a task force on psychiatric emergency services. And this task force was charged again with defining emergency psychiatric care, and then also categorizing the different levels of services that had evolved to try and see, to share this knowledge for one, but then also see if there could be national standards for this type of care. So this is their presentation. It ended up being a 100-page document that was published, still available for review, with still a lot of very relevant information. So they defined emergency psychiatric care a little different than the previous task force. They really focused on the mismatch of needs and resources. The patients that were presenting were in need of something that they currently couldn't get elsewhere, so they're presenting to an emergency department, and our job was to find and make that resource available. They also viewed emergency psychiatry as a integral part of an entire psychiatric system. So really one that fills in the gaps for a system. And it's going to be different no matter where you are, because your system is going to be different, your community needs are going to be different, and the emergency psychiatric services adapts to accommodate that. So you could see that an emergency psychiatric service in a rural area of the United States or even internationally, where there isn't inpatient psychiatric treatment even available, there are no inpatient beds, maybe for hundreds of miles, then those systems of care really developed robust outpatient treatment programs that can actually handle higher acuity patients with a higher level of risk, so that they wouldn't have to ship their patients off 500 miles to be hospitalized to then only come back 7 days later. And you can also see emergency psychiatric services with different substance use issues developing different processes. So those that had overwhelming methamphetamine addiction issues in their general emergency department versus those that had opiate crisis, trying to establish resources to provide those patients with the best care. They also identified the funding challenge that I'll talk more about, because it unfortunately persists today. that there really isn't a good stream of funding for emergency psychiatric services. Most services for emergency care are lumped into inpatient bills. So it's billed as a level of care when a person gets admitted. And when they get discharged, they usually get a bill for their emergency medical treatment, but not necessarily the psychiatric evaluation and the psychiatric treatment that is happening in most emergency departments nowadays. So many places have supplemented this with grants or contracts with agencies to provide additional funding. And this has caused some of the chaotic staffing patterns that you see in emergency services, that you'll have, instead of having dedicated providers, they'll actually just have providers who are free from other services covering the emergency department at a particular time and day. And then there's nobody dedicated to that care throughout the day. So the goals of an emergency psychiatric service. This is actually something that has come out of the several of the founding members and key members of the American Association for Emergency Psychiatry. And it really kind of explains what we do and how we do it. That in emergency psychiatry, our number one goal is always to exclude medical etiologies of symptoms to ensure medical stability. So it's during our evaluation, we are assessing to not only make sure that this patient is safe, that they have or don't have a psychiatric illness, but that they do or don't have a medical condition that could be mimicking a psychiatric disorder. And there's so many of these medical mimickers that look like psychosis, look like depression, look like mania, look like anxiety, that if we don't rule out these conditions, that actually can be quite dangerous for patients to go home or even be admitted to an inpatient psychiatric facility that may not be able to care for these patients. Things like thyroid dysfunction, intracranial bleeding, seizures, encephalitis are just a few of dozens of different conditions that could be a whole other grand round talk someday around the different conditions that look like psychiatric illness, but really are not. And if we miss them, they can actually have pretty deadly consequences. We also know that a large percentage of our patients are going to present to the emergency department with comorbid chronic medical conditions like hypertension and diabetes that may be untreated or undertreated. So these conditions require constant observation and treatment, which most of our patients aren't getting on an outpatient basis. They may or may not be able to manage that. So that comes into part of our evaluation process, is determining, can they safely manage this illness outside of the hospital? If not, then we need to come up with an alternative care plan. And then also making sure that if the patient does need psychiatric admission, can the inpatient psychiatric facility still manage this patient even with a chronic condition? If it's acute enough, they may not be able to manage that acute hyperglycemia, hypertension. And we also have to make sure that those conditions aren't affecting their cognition, aren't affecting their underlying medical and psychiatric presentation. So I see the next few goals as closely intertwined, that us rapidly stabilizing a crisis is bread and butter of what we do, but the last three are the ways that we do it. That when a patient presents to us dysregulated, out of control, it's not only disruptive to them, to the emergency department, but to the other patients in the emergency department. It affects the care that they're giving, because more staff have to be attentive to them, taking away from the care of the other patients. That it becomes a true emergency. And just the recognition of that this is an emergency situation that needs attention is step one. And so many places take a long time in coming to that recognition and really have a hard time seeing behavioral health episodes as a true emergency. And it's really integral to patient care and being level set as the same as those medical patients that are coming in an acute emergency and needing the same type of acute intervention. And the way that we do it, trying to avoid coercion and having that therapeutic alliance with a patient goes hand in hand with our approach to evaluation, that we really want to evaluate a patient so that we get the best understanding of what's really going on with them in a way that is comforting to them, allows them to open up. So when we are attempting to evaluate somebody in a disruptive, busy part of an emergency department with no privacy, and they're paranoid and psychotic and unable to speak because of all the chaos going around them, we're not going to get the good psychiatric evaluation that we need to actually make a proper disposition. We actually need that patient to be in a more private area, in a less disruptive area, in order to have a good evaluation of the patient. And that allows us to formulate our appropriate decision and aftercare plan. Then we can finally get to that place where we can make an appropriate disposition. So I'll go through some of the different models of emergency psychiatric care that exist today. These are the ones that they described in the task force recommendations. So the first is psychiatric emergency services in a medical setting. So this is the most common type of service that's out there. This is the same model that we have at Hartford Hospital with the Purple Pod being embedded in an emergency department, where we provide psychiatric consultation to the emergency medicine providers that are evaluating the patient and determining that they need a psychiatric consultation. So it obviously requires a lot of coordination with emergency medicine. They have to understand what we do, how we're doing it, what our limitations are, what our requirements are. If they feel like the patient needs a psychiatric evaluation, but they also have other coexisting medical conditions that still haven't been ruled out as needing medical admission, then we really can't see that patient yet. They really have to understand the limitations of what we can do with a patient. Same goes for patients in withdrawal, although that can go a little bit back and forth based on treatment that they're getting. So it requires a lot of coordination of duties and staffing. It comes with a high overhead cost. We take up valuable real estate in Hartford Hospital Emergency Department. It requires 24/7 staffing, depending on your size. Obviously, with our size, we staff 24/7, but most of the other, actually all of the other emergency departments in Hartford Healthcare don't staff 24 hours a day. Some could, and it may be a future state, but either way, it's an expensive model of care. Though we can handle the most complex level of patients. We can handle those that are acutely psychotic, manic, unpredictable, those in alcohol withdrawal and opiate withdrawal. We can handle a lot of medical comorbidities. If a patient needs insulin, we can give insulin. If they need supplemental O2, we can do that. It becomes tougher when you're trying to mix children and adolescents into this population. Some places do it well. We're fortunate enough to have CCMC right across the street. So we don't get a lot of children and adolescents in the Hartford Hospital Emergency Department, but in other places with this model, it becomes a very tough mix of trying to integrate how to care for and assess children and adolescents in this type of setting. So another type of service is as a psychiatric emergency facility that is separate from an emergency department. So these are freestanding centers that require an affiliation or some type of agreement with the levels of care that they would need from these places. So most of these places are drop-off centers for EMS, for police, that they can bring somebody in an acute psychiatric emergency to this facility and basically drop them off for evaluation. Because they're freestanding, because they're not part of an emergency medical department, they require a lot of triage up front. So they have to make sure that they don't have an acute medical condition right at the door. They have to do that early on, because if they do, then they obviously can't stay at this level of care. They'd be transported to an emergency department. But if they do need psychiatric and substance treatment, these types of facilities provide it all. They literally can get somebody into substance treatment, psychiatric treatment, a lot easier than most embedded emergency departments. They have a tougher time with the geriatric population. They handle children and adolescents pretty well, but the geriatric population that usually requires laboratory evaluation or a bit of a better medical workup, these types of facilities generally struggle with those types of patients. Then you have the psychiatric urgent care facilities. So these are basically clinic-based operations where they are readily available for assessment. They generally offer open access for urgent care needs. So if a patient who's not part of their clinic needs to be seen, they can see them the same day. As same goes for those patients that are in their clinic that need acute treatment. These tend to be much more patient-friendly. They're voluntary clinics. They are unlike our facility at Hartford Hospital and even most of the freestanding emergency psychiatric centers, where we require a patient to change into hospital attire. So we separate them from their belongings. We scan them for dangerous objects. We are a locked facility. These are not locked facilities. These are allow free access for patients to come and go. So they're much more friendly for the patient side, but they're not appropriate for patients with impulsivity or you're worried about high risk acuity. They cannot often accommodate medical comorbidities. So if a patient needs a medical workup, they usually have very limited ability to do laboratory evaluations. And most of the time, those patients would need to be sent to an emergency department. Now, they're also not usually 24 hours a day, 7 days a week. Most of these are operate only on certain days of the week during certain times. So where are we today in emergency psychiatric care? So when I started, the general thought was that there are about 5% of the general population of emergency medicine visits were behavioral health visits. This number has steadily gone up over the last 18 years to now being closer to 12% of the total number of ED visits involve a behavioral health complaint or concern. That the number of adults and child and adolescents presenting to emergency departments has grown tremendously. One thing that still has not changed is the average length of stay for our patients continues to be nearly twice as long as for emergency medicine patients. particularly those waiting for admission. But even those being discharged tend to spend twice as long as an emergency medicine patient being evaluated and discharged. The percentage of our patients needing admission is usually more than double what it is for the general emergency medicine population. That emergency medicine typically admits between 12 and 25% of the patients that come into the emergency department generally need admission, where in psychiatry, it's usually around 40%. So these, in combination, created a national phenomenon called boarding, where we have patients waiting for inpatient psychiatric admission, sitting in emergency departments for long, long periods of time. And this is something that's widely variable. If you live in an area with access to inpatient psychiatric beds, in Connecticut, we're pretty lucky with the number of psychiatric beds we have for our population, then your boarding time is dramatically lowered. But if you live in an area with fewer beds, you could have patients spending routinely days and weeks in the emergency department waiting for beds. And we go through phases of this where it becomes a huge issue for us. But in other places, it's common that it's just all the time, 24/7, 365 days a year. They don't have access to beds, and there are patients boarding in their emergency departments. So this has gotten a lot of national attention from the emergency medicine side. They recognize the impact it has on their entire emergency department functioning, that it causes a cascade of effects, which we'll get into in a little bit. So COVID and ED visits. So this is something that I actually really don't want to comment on too much because we are still in the midst of this. I wish I could say I had definitive data on the effects of COVID and emergency department visits, but we know it's only going up. And anything I say now would be totally incomplete and just conjecture. This is from a CDC publication in JAMA Psychiatry, where they were just comparing 2019 to 2020 and noticed all of these mental health conditions increasing year over year. And we know social isolation, we know all the negative effects that COVID has had are only likely to cause acute problems, but also chronic conditions that are gonna, in turn, increase psychiatric needs. So where are the gaps in emergency psychiatry right now? As I said, we have these long lengths of stay in emergency departments and psychiatric emergency facilities. And this has a cascading effect on emergency departments functioning themselves. So for every patient that we have sitting in a hospital, in a stretcher outside of the purple pod, it requires a staff member. That takes a staff member away from caring for usually a half a dozen to a dozen other patients in the emergency department. It takes a bed from somebody who's usually waiting now in the waiting room because they couldn't go back. And that may cause somebody who's coming into the emergency department to see a busy, crowded waiting room and then not come in at all. So it has this huge cascading effect. It also is horrible for our patients and their family members. It's a huge dissatisfier for a patient to be told that, yes, you're sick enough to come into the hospital, but no, we don't have access to a hospital bed, so you're just going to wait here. And hopefully we'll find a bed for you. It's a staff dissatisfier too. We struggle with a lot of turnover in emergency medicine staff because they go into emergency medicine because of the quick pace, because of the, they love the environment of care. And when they're asked to switch to an inpatient model of care, they really struggle and they'll choose to go other places. We also set up patients for future avoidance of emergency psychiatric care. And I think this is one of the understated long-lasting effects of poor emergency psychiatric care, is that the next time this patient experiences a crisis, they know they're going to wait 16 hours to see a psychiatrist, or 3 days to get admitted. They're going to do everything in their power to avoid coming to the emergency department the next time. They're not going to notice symptoms early on and say, things are not going well. I need treatment. Where can I go for treatment? Oh, I can go to the emergency department and be seen and be evaluated and get the right treatment. No, they're going to think, I'm going to go to the emergency department. I'm going to wait 4 days and get nothing, and then end up on an inpatient unit. So maybe I'll just tough it out and try and avoid going to the emergency department at all. So when we do emergency psychiatric care well, this has a long-lasting effect on our patients, staff, and family. We still have a lack of access to inpatient psychiatric beds and a lack of substance treatment facility access from emergency departments, which I'll talk to a little bit more. So what do we do? How do we combat long lengths of stay in the emergency department? Well, it starts with our own processes, that we have to be efficient in providing medical evaluation and psychiatric evaluation, and coming up with a plan quickly. The longer we delay that, the harder it is for the patients. They're sitting there in acute need, needing treatment and not getting it. Some places have tried coordinating this, doing it together, doing it in a less sequential fashion. But anything we can do to help facilitate that timely evaluation improves the process. Initiating treatment early. So we're not waiting for that magical threshold of saying that somebody needs admission. So we're not going to add an antipsychotic or consider a mood stabilizer until they're admitted. We're going to start that in the emergency department. We're going to recognize that you need treatment, and we're going to start that treatment. That we can establish relationships, excuse me, with all different levels of care, so that we're not just thinking about inpatient admission. So one really powerful concept is the fact that we may be over admitting patients in psychiatry, that our 40% admission rate maybe should be more like medicine's 20%. Our patients may not be that different, but we're just not accessing outpatient services the same way. That there isn't a fine-tuned enough relationship with those levels of care to get patients there with the right information to the right setting. And then we can improve the patient's experience in the emergency department itself. And it starts with training our staff. It's getting them to recognize everybody from the nurses doing their orientation to the unit, the PCAs doing the bedside patient care, to the psychiatric staff, to the emergency medicine staff, really understanding mental illness, understanding the approaches to dealing with somebody in a crisis. So much of what we do in the emergency department is set up by that orientation process. It's when they enter into the purple pod, what are they told is going to happen? What can happen? What can't happen? All of those things really set up their experience. And if we're not doing that right, if we're not telling them that there's a phone on the wall that they can use, and they think that they're just stuck in a room with no way to communicate, that's going to really color our evaluation when we get to see them, but also their entire experience throughout the emergency department. We can do a much better job in weight management in the time that they are sitting there, that they're not just staring at a blank wall, twiddling their thumbs, that they actually could be getting access to some treatment early on. They can be using things to help distract them or fill the time, but also doing things that can actually provide treatment. and peer supports. This has been a tremendous asset to our emergency psychiatric services at Hartford Hospital. It really builds off a national movement that has become a best practice and a standard of care in emergency departments and in behavioral health units across the country. We have people in recovery themselves connecting with patients in the emergency department to really enhance their experience, really help them in the moment connect to us, connect to treatment. Then bed access. So what can we do about bed access? So this is the other part of one of my jobs in Hartford Healthcare is our Care Logistics Center, where we're a centralized referral process for patients that require inpatient psychiatric admission, that we're fully utilizing all of the beds in the system. Many places don't have a center of care like this. And before we had the Care Logistics Center, we were reliant on a social worker in the emergency department calling each and every one of the psychiatric hospitals across the state to find out if they had beds available, and if so, would they consider a patient from our purple pod. We'd fax them information. It would take all day going back and forth to figure out if they'd even accept the patient or not. Meanwhile, we're referring to several other facilities and trying to coordinate all of those referrals for the dozen patients that we admit every day is cumbersome, discoordinated, and really not effective. So having a centralized place to do that, where the emergency department determines that they need that level of care, they make the referral, and then we get to place them into the most appropriate bed for them. The emergency departments get out of the bed management system. They don't have to be involved in deciding where's the most appropriate place for a patient. That's left up to a separate entity. Coordinating services and simplifying referrals. So this is the way that we can communicate better with outpatient psychiatric treatment, so that when we are making a referral to an intensive outpatient program, they understand our assessment, they understand what treatment we've done, what assessment we've done to determine this is the right level of care for the patient, and making it easy for the patient to get there quickly and get the right treatment that they need. And then coordinating treatment. So when the patient does need inpatient treatment, we're actually coordinating with the inpatient side so they understand what we've done in the emergency department, why we've made the choices we've made as far as medication choices and treatment options, so that then they can build off that. So it doesn't become 2 to 3 days wasted in the emergency department, that their inpatient admission starts when they cross the threshold of inpatient, that really that inpatient treatment can start in the emergency department, and it becomes a continuation once they do enter the unit. Then access to substance treatment. So this is something that we still struggle with, and really is a great deficit in our system, where early on we need to identify who's appropriate for dual diagnosis inpatient treatment, who really requires substance and psychiatric treatment simultaneously, and who really needs substance treatment that's not based in a psychiatric hospital. And those can be challenging early on because we get a lot of patients presenting with suicidal ideation or acute psychiatric symptoms that may make them look like they're unfit for a substance facility, but really teasing that out and doing that appropriate evaluation for the right patient. So one thing we get stuck with is we do an evaluation, we do a behavioral health initial eval on everybody. And when we fax that to substance facilities, it looks like it's a psychiatric evaluation. So it makes the patient look psychiatric and less like a substance use disorder patient. So other places have started doing a substance evaluation separate from a psychiatric evaluation, so that those referral processes can become more streamlined. Establishing relationships with detox and rehab centers that we really need to do a better job in coordinating treatment directly to these facilities. Our recovery support specialists in the emergency department and CCAR have been tremendous in helping our patients access these levels of care. But I think administratively, there's more that we could do to help foster those relationships. And I did not mean to skip over starting substance use disorder treatment in the emergency department, because I think it's a huge step. It's a national standard. This is something that my colleagues down at Yale have been studying and doing for several years now. Gail D'Onofrio and Kathy Hawk have really done tremendous research on the benefits of starting buprenorphine in the emergency department, and really found that it not only helps the patients acutely, but helps them in the long term, and has really become a national standard that we need to implement. So I already talked about the benefit of peer support, but also the discharge planning. So unfortunately, for many patients with substance use disorders, we don't quickly get them access to the treatment that they need. It's delayed. It's not available that day. They're going to have to call back the next day. They're going to have to keep continuing this process after they leave the emergency department. It doesn't mean we don't provide them with any care in the emergency department, or that we didn't provide them with any care, that we need to have an active role in that discharge process. We need to not only explain to them what has been done and what needs to be done, but also offering them treatment, medication, education around naloxone, education around other options of treatment. So really engaging in that discharge process instead of just handing them a piece of paper. So I do want to quickly talk about two other models of care that are out there, the crisis stabilization units and empath units. So crisis stabilization model is another one of those levels of care that varies tremendously state to state, region to region, really based on resources that are out there, and a little bit by psychiatric commitment law, but they are typically designed as a residential level of care. They don't replace inpatient. They don't take the patients that are unpredictable, acutely psychotic or manic, but they really embrace the living room concept, where a patient can come in crisis, be seen, and have a place to be, to de-escalate, to get away from whatever they're facing in the community that makes it unmanageable at the time. And these units can accommodate people sometimes 23 hours, some places 72, some places they convert it to a residential where they can stay even longer. They're staffed well with multidisciplinary treatment. They can see a psychiatrist. They can get started on a medication if needed. They can have case management, social work involved. These places are often tied to mobile crisis teams and telephone crisis services. So that's their referral process. There was actually a best practice toolkit published recently to give national guidelines for behavioral health crisis units. And this is the standard that was put out there. Unfortunately, there is tremendous variation, that not all places operate the same way. I'd love it if they did. I'd love it if we had this level of care available everywhere, but unfortunately we don't. And that gets back to the funding problem that we'll talk about a little bit more, that it's a hard level of care to pay for and to sustain. So the empath units, these are emergency psychiatric assessment and treatment healing units. So I think it's a term coined by a company out of California. They didn't license the term, so they didn't copyright it. So it's open for use. But they've set up a number of these units throughout the country. They typically are hospital-based, but billed as an outpatient level of care for all levels of psychiatric crisis. So typically a patient gets evaluated in an emergency department and then referred to these empath units where they can get psychiatric treatment. They can stay for several days and potentially get referred to inpatient if needed or outpatient if they need it. But they found that they're discharging most of their patients within 16 hours. The unit itself is an open concept. They don't have rooms. They don't have a centralized nurses station. They usually use chairs that can recline for beds for overnight care. But they really embrace the open concept, open milieu as a way to help de-escalate crises, to really help patients feel more comfortable. So what does the future of emergency psychiatry look like? And what do we need to do better in emergency psychiatry? So I think the biggest thing is we need to extend beyond our brick walls, that it should not be facility based, whether it's an ED or a crisis unit or an empath unit. By the time the patient arrives to us, the emergency has already happened. The system has already failed. So to be truly effective, we have to be more proactive. We have to work with communities. We have to establish community-based supports for patients. We need to work with EMS and police. So this is another national movement. And actually we have quite a bit of work being done locally to try and do this as well. Kind of working on a national trend of having non-emergency medicine, non-police evaluate people in the field who are in behavioral health emergencies. So instead of calling 911 and getting a police response, they can call and get a civilian or a community responder response. But there's still going to be some calls that go to 911. If there's any threat of harm to anyone, these are still going to go into the 911 queue, and police and EMS are going to respond. So we need to do a better job in educating EMS and police on behavioral health emergencies, what they look like, and how to de-escalate them in the community so that they don't escalate even more and put patients at risk and police at risk and the community at risk. We need to expand access. We really need to have more places available for people to go in crisis, that the emergency departments have become the option of choice because we're open 24/7, because there is no other option most of the day, most of the time. Telepsychiatry has become a national movement. Many places, remote emergency psychiatric centers had actually started long before the pandemic in providing telepsych services because they were so remote and it was so costly to get a psychiatrist in front of a patient in an emergency department in the middle of North Dakota, that they would contract with an urban center to provide that rural care. And there's still tremendous amount of growth opportunity there. I think anything positive has come out of COVID. It's that we're all become a lot more comfortable with providing these evaluations and doing them. They may not be ideal for all patients and all services, but when the option is nothing compared to it, I think it's a tremendous benefit. And then integrating services, so being able to work together, inpatient, outpatient, all of our different levels of care, so that we understand what each level of care can do, what they can't do, what type of patient is right for them, and how we can get patients to them and move between those levels of care effectively. I think at Hartford Hospital, we're really a step ahead of most other places because we have one electronic medical record. We have almost everybody on the same system of care. we just need to do a better job of getting out of our silos of treatment centers to come together to really integrate our care. And then nationally, education. So our psychiatry residents do a month of emergency psychiatry care. There is no standard in emergency medicine for them to do any psychiatric care or treatment or rotation. Some programs have set this up, and the University of Connecticut does give the emergency medicine residents 1 week in psychiatry training, which is still better than none, but not as much as it probably should be if we really want to effectively prepare them for dealing with the number of behavioral health emergencies that they're going to face as an emergency medicine doctor. So we need to enhance that education. There's also a national movement for creating an emergency psychiatry fellowship, making it a board eligible subspecialty. A resolution was passed by the American Psychiatric Association Assembly to investigate this, and the AAP is currently investigating it, and we're putting together guidelines for it and making a proposal for it. And we hope it goes through. There are several already in existence. They're just not board eligible subspecialties yet. So the training is out there. It's just doesn't provide that same board certification. And then the big funding question. Unfortunately, I don't see a national answer coming to our funding problem. I don't see a nationalized healthcare service, a national healthcare funding stream coming to pay for emergency psychiatric services. So really it's left to the local and state agencies to coordinate payment for these services, to see what's valued, see what is needed in each area, and to fund it. The trend over the last few years has been grant funding, which is great. It gives a big influx of money. It allows us to demonstrate that projects are going well, that we can provide the right level of care, right treatment, but it's not sustained. Grants run out. They unless they become a line item in a budget, they're going to go away. And we need a steady stream of income really to provide this level of care. So with that, I know I'm running short on time. So I'm free to take any questions.
David, that was really excellent. A great summary of essentially the past, the present, and the future. Can let people either write questions in the chat, or if they want to unmute and ask a question. I had a question, if you don't mind. If you could think about what we might look to implement in the Hartford area, what would our community benefit from as far as some of the new models of care?
Yeah, I mean, I think the big obvious deficit for us is local substance treatment facility that we have. Hartford Healthcare has Rushford. They provide great treatment, but it's mainly for the Middletown area. It's really hard for us to access that in the Hartford area. That relationship with community providers, I think we do a good job communicating with some of the agencies, but not all of them. I think coordinating with mobile crisis, coordinating with the police response team, or the community response team that is going to be working in handling a lot of these behavioral emergency calls, I think is key, and that's another area that we need to go.
Looks like Dr. Fox has his hand up.
Yeah, hi, David. Thank you very much. Having grown up in the system with you, I just want to put a plug in for what it means to be dedicated to a field, take on a burgeoning field, and create an expert in our system. Like David, he has not only become very knowledgeable both locally and also nationally, but he is a trustworthy leader in our system. And these challenges are for all of us, but really appreciate the summary and the interdigitation of all our services as they often begin through your doors. So we realize the challenges and frustrations. Often we as end users feel them, but at the same time have to recognize that we also have to care for those that are doing their best in your service. And for that, really want to thank you. I also wanted to just put in a pitch, because not to cause more headache and stress for Scott Siniscali, our latest attending, but he is developing the part of the integrated outpatient system that you're talking about regarding urgent care. And hopefully that too will develop in time with your tutelage. So thank you very much. Appreciate it.
Thank you. Yeah, it does feel a little, oftentimes as an underappreciated service, because we are that front door to so many other services that spend a longer time with their patients. Inpatient and outpatient get to spend a much longer time helping the patient, and we have such a minute period of time, but I think we have the opportunity to do a tremendous amount of work, and I think our staff does a tremendous job. I always tell them that they do such a great job with a short amount of time, high acuity, and we still get it right, and we do a great job trying to provide the right care for the patients at the right time. I'm trying to read through the chat to see if there's another question.
Dr. Widener was wondering the name again of, I believe it's the empath movement.
Oh, yeah, there's a few different treatment options. That's one. It essentially functions more as an observation unit, because these patients come into an emergency department, they're evaluated to need some higher level of care, maybe not inpatient, maybe not outpatient, but they're certainly not ready to go yet. So they go to an empath unit, this open floor concept, where they can get treatment and get evaluated over a longer period of time, and then hopefully get to the right level of care. And they found that this decreased their admission to inpatient and really decreased acuity for the emergency department. Looks like Dr. Bettman has a question.
Yeah, I have just some information and then I have a question. So you may know this, David, but in order to be a new field or mostly we're talking about new fellowships, the ABPN requires that there be enough programs and enough residents, fellows in the program in order to meet the cost of giving a board exam every 2 years. And that, interestingly, is the biggest hump that new fellowships have to climb over. And mostly they do it by establishing enough unaccredited fellowships, which they demonstrate enough people going into that are paid for by the hospital, that then it becomes obvious that, it'll meet that requirement. That just as an aside. My question has to do with CPAPs. New York State has CPAPs, and I didn't know quite whether any of the models that you described meet those of a CPAP, whether Hartford is a big enough city to support something like a CPAP, how you see it as an advantage or a disadvantage to any of the other models that you proposed.
Yeah, most CPAPs, California and New York are the biggest models for them.
You may need to describe to people what they are.
Yeah, so they are the psychiatric emergency facilities that are separated from an emergency department. Now, in New York State, there are some that operate in an emergency department. So they are physically located on the campus of a hospital. I know the one in Syracuse is that way. The one in several of the ones in New York, including Bellevue, is a CPAP, but it's integrated into an emergency department. And they're designed to take any type of psychiatric emergency, to do an evaluation, but also to provide treatment. So they don't have the same push to get people out in under 8 hours as we have sitting in an emergency department. That they're often admitted or observed in that unit for 24 to 72 hours. And a lot of that depends on regional emergency psychiatric law and how long they're allowed to hold them involuntarily. I do think that looking at some of the areas that have developed these centralized emergency psychiatric services, I always think Hartford could do really well if we established one. It would have to be a joint collaboration between St. Francis and Hartford, because we'd be stealing patients from both places. It would have to be coordinated with the state mobile crisis centers, Capital Region, and the local enhanced care clinics. It would also need to be tied to substance use facilities, since so many of these patients need access to that level of care as well. Houston actually put together a really interesting model where the city paid for it. Basically, they took money from each of the hospitals and they budgeted it through the system, through the city itself, to pay for an emergency psychiatric center with an in-house detox facility, an in-house rehab center. So all the patient did was move from room to room. If they needed detox, they literally would go across the hall. If they needed rehab, they'd go of one floor up. And it was a model that worked really well, but it required a lot of dedication from city leaders. And I don't know if we have that level of commitment to emergency psychiatric care. It does require a lot of initiation up front.
Well,
Some CPEP is a complete psychiatric emergency facility or program.
if you do decide to create one, I'm just putting in your mind, make sure it includes FTEs and benefits for the residents from Yukon and Hartford who will need to do who may need to do their rotations there and their electives there, and you can think about your fellowship there.
Sounds
More
good.
money.
Yeah, and getting back to the fellowship idea, yeah, it is a huge burden to try and start a new fellowship these days, and especially to get a board eligible subspecialty. I know Dr. McLean may be able to comment a little bit. I saw you jump on there because I know addiction medicine went through a similar process, and we're actually looking at that and sports medicine as a few other specialties that have gone this road recently. And how they've been able to do it.
Yeah, we can talk some more about that, but set it up as a non-ACGME approved program, but you need the funding, the authority, or the backing of the department, and then you have to get the groundswell that Adrian talked about from other programs.
Yeah, you have to demonstrate your numbers
And the numbers.
before they'll do it.
And we just this year got the match approved, so that addiction medicine will have a match. So it's a process over the last 10 years, basically, of developing that.
Yeah, since emergency medicine took almost 20 years, I think we're just at the start of our road.
David, thank you very much. Nice presentation, very informative. Is the PowerPoint available?
Sure. Happy to send it out.
I'd like to share with my staff that weren't able to attend today. Thanks again.
Yeah, no problem. And I'm pretty sure we're being recorded to, it should go up on the web as well.
Yes, thank you.
Well, we've gone over the usual Q&A time by about 5 minutes, so that sort of demonstrates the interest in this topic, and I think the quality of the presentation as well. So maybe time for one or two other questions, and if not, then we could wrap it up. I really appreciated the discussion around what could we plan for, in the future of the area. And one thing that's been on my mind is that the state of Connecticut has a $3 billion rainy day fund right now. So maybe it's time they started spending some of that.
Yeah. Yeah, one issue I didn't even talk about, and it's relevant to emergency psychiatry in that the responses are going to be coming is the 988 system, that the national hotline for behavioral health emergencies is coming supposedly in July of 2022. I think a lot of states are really behind in setting up their processes for handling these emergencies, but Connecticut, we already have 211, we already have some local integration with mobile crisis centers. So I think that we're probably a little bit better than some states who have not even looked at this process yet. But it's another opportunity for emergency psychiatry.
Well, thank you all. Have a good rest of your day.
Thanks for coming.